Hey, everybody. Welcome back to Pulm PEEPs. Thanks for tuning in today. We're excited to dive into a new episode. This topic today is coming all the way from Ireland. This is our first collaboration with the Irish Thoracic Society. We're super excited about the fact that we're going to be doing episodes with them. They have a great podcast series themselves. And so we're excited to dive in to some pulmonary topics. And today we're going to be talking about a really interesting one that comes up a lot in pulmonary clinic that I think we don't know enough about or don't teach enough about, but is very common for anyone who's treating pulmonary patients. So we're going to be talking about refractory chronic cough today, and we're going to be doing a little bit of a case-based approach as we normally do. We'll raise some of the challenges. We'll try to talk about some of the diagnosis and some of the treatment. Christina, so excited for this collaboration. How are you doing?
Hey, Dave, doing well. Really excited to see you and to be joined by some new guests today. I know that you and I say we're going to do like a road trip and go to, visit the fellows that have joined fellows case files. But I'm quite excited to potentially do a road trip to go visit Sandra and Marissa and the Irish Thoracic Society one day.
100%. Yeah, that should be our first stop. Yeah.
I think that should be the first stop for sure. But really delighted to be joined today by Sandra Green and Marissa O'Callaghan from our fellow transatlantic podcast, the Irish Thoracic Society. We'll just do a quick general disclaimer before we get into meeting our guests today, because we're all on the same page and aligned. But just as a reminder, this podcast is not meant to be used for medical advice, and the views we express today do not reflect the opinions or policies of our respective employers. The case we're going to be talking about today, as Dave mentioned, to kind of set the stage, is HIPAA compliant, and some details may have been changed to protect the privacy of our patient. But Sandra, welcome, and so excited to be meeting with you and Marissa today.
Christine and Dave, thank you so much. We are absolutely thrilled to be here, and we would love to welcome you here, Kate Mila Fulcha, so anytime. But we are huge fans of your podcast, and you were really inspiration for us when we were starting out on our journey of setting up a podcast over here in Ireland. So we've been hoping for a really long time that a collaboration like this might finally happen. There's a great line from an Irish poet, Yeats, who says, "Education is not the filling of the pail, but the lighting of a fire." And that really captures why we kind of started the podcast, and to share the voices of Irish and international educators who've inspired us and shaped how we learn along the way. And the first guest that we have today really embodies that passion, and we're absolutely delighted to welcome Professor Lorcan McGarvey. He's Professor of Respiratory Medicine at the Wellcome Bulfson Institute of Experimental Medicine and the School of Medicine, Dentistry and Biomedical Sciences at the Queen's University Belfast. So, Lorcan, you are very welcome on the show today.
Sandra, thanks very much. It's an absolute honour, and I'm looking forward to lighting a fire and hopefully inspiring all the listeners to the field of chronic cough.
Great. So Dave, Christina, Sandra, thank you so much again for letting me share this podcast with you both, and to our guest, Lorcan, and our second guest, Brendan, who I will introduce now. So Professor Brendan Canning is a professor of medicine in Johns Hopkins School of Medicine. Professor Canning is a highly accomplished researcher in the field of allergy and immunology, and has studied mechanisms behind chronic cough extensively. So without further ado, welcome Brendan, and should we dive into this case?
Great. So this case starts as a written referral from a primary care physician. The patient is a 55-year-old female. She's a classroom assistant, and she has been a long-term non-smoker. She's referred with a 4-year history of dry cough, and the cough is noted to be worse on talking or when there's a change in the temperature. The cough is rated as severe with a score of 85 out of 100 on a visual analog scale. She sometimes even vomits due to coughing and has reported urinary incontinence from coughing too. So Dave, you might start with yourself. How would you approach a case here? What kind of differentials are you thinking of?
Yeah, so I think first and foremost, Christina and I have done a lot of cases that start like this, right? Chronic cough or even acute cough, subacute cough is a super common complaint for anyone who has a pulmonary clinic. And so first things being first, we want to harken back to some of those things that we've talked about. Most coughs, when you approach them, you should approach as the typical cough. Like, what are the most common reasons that people come in coughing? In the acute phase, we're often talking about viral illnesses. In the subacute phase, post-viral being the most common. And then in the sort of subacute to chronic phase, three most common, at least in the United States, are GERD, postnasal drip, or upper respiratory airway syndrome, whichever one you want to call it, and cough variant asthma. And so we should always start with that typical framework where we're approaching people who have cough, that we might find something that we can treat, that we can reverse. And we're not going to assume that this cough is going to persist forever just because somebody's had it for a long time. But some coughs don't go away in that fashion. And so this has been a field where there's been a lot of different phrasing, different terminology, different ways of framing these patients. But more recently, a lot of the respiratory societies have sort of not come together, but they've recognized the need for a unifying diagnosis and definition here. So ACCP, ERS, BTS, they all have some definition that varies slightly. But it goes something like this, that a chronic cough that persists longer than 8 weeks and remains unexplained after a comprehensive investigation, medical assessment, and optimal trials of indicated therapy. They were very specific about that. And an adherent patient, so someone who's actually taking the therapies, might be considered a refractory chronic cough. This international consensus then falls into 3 categories that we should all consider. We have unexplained chronic cough. When we've done an investigation, we really don't have any reason that this patient is coughing that we can put into one of those common buckets. And explained but refractory cough. This is like, we know the patient has a disorder, but we just can't control it with the medications we typically do. So this patient has had pH manometry, esophageal pH monitoring. We know they have reflux. We think this is a reflux-associated cough, but with our typical therapies, this cough has not gone away. And then unexplained refractory chronic cough, when we have no cause and empiric therapy has failed. So we have unexplained chronic cough. We haven't really tried to treat it yet. Unexplained refractory is that we've actually done some empiric therapies and it's still persisting there. So when we're in the initial evaluation phase, we are going to be thinking about the common causes, and then we're going to keep in the back of our mind that if that cough doesn't go away with this initial workup, that we may be falling into one of these other categories. As I said, we need to investigate the most common causes of cough. I mentioned the 3 most common causes in the United States, which is upper airway cough syndrome, asthma, cough variant asthma, and reflux. I'm curious for our guests if that is the same 3 most common cause of cough in Ireland or on the continent. And I'll add to those 2 things that we should make sure that we are always working up for, which is non-asthmatic eosinophilic bronchitis or laryngopharyngeal reflux, which is slightly different than gastroesophageal reflux. But those 5, we need to make sure that we're working up. Brendan, we have this patient in front of us. I want to kind of turn to you because you raised a really interesting point as we were planning for this. This is a 50-year-old woman. She's had chronic cough for a couple of years. Is this the typical refractory chronic cough patient? Is this atypical? What's the epidemiology that we should be looking out for?
It is, David. And so I'm not a clinician, but I've been actively involved in the field for a long time. And one of the oddities of cough that is quite clear, and we don't know why, is that cough, and particularly chronic cough, disproportionately impacts women. So about 2 to 1 presenting clinically with chronic cough are women. And then in addition to that, it seems to be especially problematic as we age. So those are the 2 kind of classic demographics for cough patients. And I'm sure Lorcan can speak to his own cough clinic that would say this is just a typical patient. 50 years old, woman, non-smoker. I think this is classic.
I'll just jump in at that point, Brendan. And, when we put this case together, I mean, it was clearly fictitious, but I think it's built on the kind of patients I've been seeing for the last 35 years. And in terms of answering Dave's question, is this a sort of typical demographic? The answer is yes. In my clinic, it's also the typical demographic right across at a global level. In fact, some years ago, we kind of did a survey of many specialist cough centers around the world just to describe their kind of patient population. And it was, for the most part, 2/3 in virtually every country were female, often female, as Brendan has said, and female patients within their middle years of life. And I guess there's a clinical point there that should be raised is if you have a patient coming to your clinic who's kind of male and in their 30s, it doesn't mean that they mightn't have a diagnosis of refractory chronic cough, but you perhaps want to rethink your approach to evaluating that patient and maybe just caution a little bit about making a diagnosis of refractory chronic cough in a slightly atypical patient. And I think that combination of good history, some basic investigations, pointers within the history, pointers within the investigation, and then trials of therapy, and very much around what you've said, Dave. It's not just about giving the therapy, it's making sure and asking yourself, have I given the right dose? We've given you optimized treatment, you've taken it, and your cough persists. That doesn't mean you don't have asthma. It means you have asthma, but optimized asthma treatment has not resulted in a improvement in your cough. Your cough is refractory. So this is kind of how we framed this kind of anatomic diagnostic protocol approach to evaluating patients with chronic cough. And for the most part, it has served well. But there are clearly patients that do not respond to that approach. And I think those are the patients that your listeners are scratching their head with and saying, how can we be helped?
Thanks so much, Lorcan. That's really helpful. It's obviously a challenging history to try and drill down. Is there anything in particular that you ask during that history, or any tools you use to try and understand more how it's affecting the patient and how you can get to that diagnosis?
Yeah, I mean, look, when I see these patients, I start off just, in fact, something that I would really recommend is just say to the patient, tell me about your cough. Tell me what you mean by cough. Because very quickly, the patient might be describing something that sounds rather more like throat clearing, that's what's bothering them, rather than a cough per se. Or they will talk very often about when they cough. One of the points I wanted to get across in this podcast is that patients with chronic cough, they don't cough all the time, day and daily. I mean, rather, they describe episodes of coughing, bouts and spasms of coughing, and very typically triggered by relatively innocuous things. They say, I find when I move into a room where there's a change in air temperature, that sets me into a bout of coughing, or I'm on the telephone or somebody makes me laugh, or I'm about to eat a meal and the food odors set me into this spasm of coughing. So getting that in, as a first approach to your history is important. I mean, obviously asking things about, do you smoke? Have you stopped smoking? Red flag things like, do you bring up phlegm? And clearly, a patient that's bringing up large amounts of phlegm will direct you down probably a different, for the most part, patients that I see in my clinic. And I think the patients, Dave, that you were talking about, they generally report predominantly a dry cough, not exclusively a dry cough. And please do not expect that your patient says absolutely no sputum at all. Very often they'll describe small amounts of scanty sputum that can be difficult to expectorate. That's often a typical feature. But a lot of sputum would probably bring you down a different route of investigation. So those are the sorts of things that I begin with when I'm doing a consultation. And I think that point of asking the patient to tell us about your cough, how does it bother you, is important.
That's great. Thank you for going through all that, Lorcan. I totally agree with so many points, like the trial of therapy. Sometimes the patient takes a week of reflux therapy and they say it didn't work and they stop, and we know that that's not long enough. And then I should highlight too something very specifically that you said for the listeners is you do have to have your heads up for red flag symptoms, even when someone tells you they've had a cough for 4 years. If they are having hemoptysis, they've had weight loss, they have had recurrent pneumonias, they're bringing up suppurative sputum. They're associated with hypoxemia. They were admitted to the hospital and discharged on oxygen associated with their cough. These are all things that are not typical of this refractory chronic cough syndrome we're talking about and may represent more underlying parenchymal lung disease that we have to look into. But we have a great framework for going forward into our case. So Marissa, can you share some more history from our patient?
Thankfully, we took a really thorough background history from our fictitious patient, so I have lots more information to share with you. From a history point of view, this has been a daily problem. The coughs come in bouts, worse first thing in the morning. She's also been having some difficulty sleeping due to the cough, but isn't woken by the cough that often during the night. She describes typical triggers as being talking, exposure to air conditioning, aerosols or scents in the air, and dry, crumbly food. Very occasionally, there's a small amount of sticky phlegm, but phlegm isn't her biggest problem, and she denies any hemoptysis. She was quite concerned about the impact of cough on her employment. Remember, she works as a school assistant, so she's been referred to occupational health by her school principal, and they're investigating things from that side of things. She denies any breathlessness, wheeze, chest pain. She's no real rhinitis, but does have an occasional drip at the back of her throat, and she clears her throat quite often. She's no initiating upper respiratory tract infections, no syncope. She's been pretty well prior to this. She had a previous history of heartburn during pregnancy, but doesn't suffer from heartburn anymore. She's not on any regular medications and particularly no ACE inhibitors. And as Dave mentioned, important to see about prior failed treatments. She reports good compliance and adherence and has had a 2 to 3 month trial of anti-reflux medications. She took acid suppression and prokinetics. She's had a 6-week trial of nasal steroids with decongestants and took an antihistamine alongside that, and also took a 6-week trial of montelukast. So she's really been put through her paces, and none of those have had any benefit for her. In addition, she's an entirely normal physical examination and the patient is not obese.
Thanks so much, Marissa, for providing some additional details, which I think are so important and cover a lot of the great pearls that we've already talked about today. But how am I thinking about this person as I'm listening today? I wanted to just kind of provide a problem representation before we move on to the next topic. But I would view this patient as a 55-year-old immunocompetent woman with a 4-year history of chronic, predominantly dry, trigger-induced cough associated with throat clearing and post-nasal sensation, normal physical exam, and no response to empiric reflux, upper airway, or asthma-directed therapies. And I think it's very clear that, the symptoms that she's having is really impacting her overall quality of life, and something that I think we should take seriously and really work with this patient to try to identify additional etiologies or therapies that we can provide. Brendan, I'm interested, though, if you could share a little bit on hypersensitivity, given some of the triggers. I know we alluded to this earlier, this concept of cough hypersensitivity syndrome and how it overlaps or plays a role in refractory cough diagnosis.
Yeah, cough hypersensitivity actually has been a useful concept for us. And if you listen to the history of that patient, we heard about triggers like changes in temperature and sensations from smells, etc. And this is classic, I think, when we hear about these patients. We can then relate that to some of the sensory innervation that we know exists in the airway. So, of course, cough is a vagal reflex, and we know a lot about the types of sensory nerves that will initiate coughing. And so it's been a useful concept to think about this. It hasn't necessarily changed how you would approach a patient clinically, but it does change our thinking about how to approach developing new therapeutics. And I think that's a valuable contribution to the field. So cough hypersensitivity is really helped us a lot. I'm going to just jump in on something that Lorcan was mentioning, and it came up, the visit to occupational health. I'm a bit of a sidetrack here, but that is one of the things that we hear quite often in the cough field. These patients have been through lots of trials with their primary care providers, and they often end up dejected when they end up in your clinics because a lot of things they've tried have failed. And so I think being aware of the kind of mental health consequences of a symptom that persists for years in these patients without benefit from therapy, I think is an important thing to keep in mind.
Very much so, Brendan. I'm glad you brought that up. In fact, when we think of the health burden associated with cough, and some of it is dominated, or a lot of it is dominated by the journey that they've often been on. And in this case, it's been 4 years. But as Christina summarized, she's had multiple trials of therapy, presumably multiple investigations, and she continues to cough. But we often think about splitting this burden into 3 domains. There's a physical domain, so just the kind of repeated, persistent coughing, and that might be, chest wall pain. It might be, and in some cases, it's not unusual for us to have patients that have syncopal episodes during bouts of intense coughing, or maybe even episodes of pre-syncope, and that can impact on things like driving, different types of occupation, et cetera, et cetera. Urinary incontinence is one of the most striking things that doesn't always come out in the first consultation. There's clearly an embarrassment associated with urinary incontinence. And this lady in this particular case, is troubled with urinary incontinence. And we see this as being really quite disabling. And then if you put the physical elements in, clearly there is a social element. And since COVID, the stigma associated with coughing in public is quite striking. And there's undoubtedly patients have told me that they feel much more self-aware if they're coughing in public. And indeed, many will tell me about being told in public, you shouldn't be out, please, stop coughing. So this kind of physical, social, psychological component needs to be thought about. And that's exactly, I think, what Brendan was kind of touching at. And we will say a little bit about how do we measure this? And this is important both from a clinical perspective, really understanding the impact of the problem in your patient. But also if you're developing novel therapies, you've got to get some measure of health burden, and some of the tools that have been developed around quality of life and so on are starting to try and address these elements. I mean, it's interesting. And one point I'd like to highlight in our fictitious case, Sandra told us about this idea that she rated her cough severity on a scale, presumably from 0 to 100 at 85. One of the things our guidelines are really telling clinicians now to do is, let's keep this simple. Let's just get a 0 to 10 scale, 0, no cough at all, 10, the worst imaginable, and just tell us where you are at the moment. That can often be a useful baseline, so that when you see them next time, you hope, well, the intervention, they used to be an 8, they're now a 6, or the 6 is now a 4, or the 4 is now an 8. So this idea of capturing the impact on a simple scale, I think, is now widely accepted. It's built into a lot of our clinical trials. And while it's a bit unidimensional, a single measure, and maybe it's hard to tease out what bits are causing burden. Is it the physical element? Is it the sleep disturbance? Is it the social embarrassment? It's complex, but we shouldn't forget to at least measure it and acknowledge it.
Yeah, it's a bit like the dyspnea scale, which is quite useful as well, I think, and has value in internal medicine.
Absolutely. Having a validated scale, or at least a consistent way that we do things, definitely helps, especially for repeat visits, because you say it the same way, the patient rates it the same way, and then you can sort of judge and say, hey, looks like we've made progress or not. The psychological toll is a really good segue here. One of the things I'll add to one of the tolls that these patients can have is that often their diagnostic workup will go in circles, right? So they'll see some people, they see an IM doctor, see a pulmonologist, get an x-ray, get PFTs, maybe get a bronchoscopy. They'll send them to an ENT. ENT will say something mild or something nothing. And then a year later, for some reason, they're back in a hospital or they're with a different doctor and they start it all over again, when we know it's going to sort of be the same. And so having a really good framework for this is one of our takeaways for our listeners for this episode. So we want to try to avoid repetitive or unnecessary testing. We know that we can help people with chronic cough, even if we don't have, maybe the most diagnostically pure where you say this is explained or not. For someone like me, I'm like a little bit of a diagnostic purist. I love to know exactly what it is. And so this is tough for me, but something I've grown into. But I do always then harken back to those 3 big categories of, explained refractory, unexplained chronic cough, unexplained refractory chronic cough, where we just have not made any progress. And so I do, when I have one of these patients, I say, I don't want to repeat everything, but I also don't want to miss anything. And so I kind of look through their workup and make sure I think they've had at least one thorough evaluation. As we've highlighted, that's history and physical. To be specific, again, we want to make sure we're ruling out those red flag symptoms that might bring us down a different pathway. Systemic symptoms, weight loss, hemoptysis, recurrent pneumonia, dyspnea or hypoxemia that's out of proportion. If we don't have those, we're always going to review medications and environmental triggers. Almost all these patients will have an x-ray at some point. They probably should have an x-ray at some point. If they, it doesn't have to be a CAT scan right away, but like at least an x-ray to make sure the lung parenchyma looks okay. PFTs and bronchodilator testing. And then the workup sort of goes into some of your judgment, and you have to decide what's necessary or unnecessary testing. And Lorcan, this is where I want to turn to you. What tests would you say for like this patient who's had an x-ray, she's had PFTs, she's had a couple of empiric trials, like what are the next tests where you'd say, you really need to have this. I don't want to repeat. I don't want to run you through the ringer, but these are the tests that I really think are important for you to have.
Yeah, that's a really good question, Dave. And I guess I'm going to use the phrase now, which is less is more, because you're absolutely right. What these patients often tell us by the time they come to maybe a more specialist center is that they have been on this journey of numerous investigations, numerous trials of therapy, and it's kind of been circular and often repetitious. But we undertook a Delphi survey really to try and get some consensus among cough specialists worldwide as to what would be the key investigations you'd want to be taking, at the start. And it's definitely, it's, as you say, it's chest x-ray, it's spirometry. It then starts to move into some measures of T2 inflammation, and peripheral blood and pheno are certainly right up there. And there was broad consensus that those should form the kind of basis. The other thing that the guidelines have tried to do, I think, and I'm talking about ACCP guidelines, I'm talking about ERS guidelines, I'm talking about British Thoracic Society guidelines. We've tried to frame the investigations in a slightly more judicious way, whereby not every patient should get every investigation. Really, if a patient is not reporting a lot of acid burning dyspepsia type situation, it is unlikely that 24-hour esophageal pH monitoring is going to be abnormal. You will always get exceptions, but in general, when you're trying to rationalize the approach to patients that otherwise would get every investigation done to within an inch of their life, we're really trying to rationalize what is appropriate. And it does come down to the history. And in fact, if a patient is reporting a lot of indigestion and heartburn, I'm not going to do a 24-hour esophageal pH test to confirm that. I'm going to go straight in with a trial of acid suppression. And similarly, if you have a patient who, upper airway cough syndrome is a condition that's recognized, but if they absolutely do not report nasal congestion, they have no sensation of blocked nasal passages, sinusitis, rhinitis, I am not going to organize a CT scan. I may not even organize beyond my own relatively rudimentary assessment. I'm not going to organize a full ENT workup. So it's about thinking less is more, but at the same token, you don't want to miss important things. We come back to the red flags. We come back to things like, let's actually examine this patient. Think about, do I need to do all of these investigations all of the time in every patient? And the answer is no. It's about a good history, good physical, and then targeted investigations accompanied by optimized treatment. And I think that is the journey you want to go on, to the point where then you can say, and don't be afraid to say to the patient, we've worked you up. Common conditions have been excluded. You've had trials of therapy. You have features that really look like a condition that we recognize called refractory chronic cough, with elements of cough hypersensitivity. I promise you, your patient will be glad to at least recognize that first, it is a real condition. Secondly, you recognize it. And thirdly, there may be hope for treatment. And I know during this podcast, we'll get on to treatment and so on. But I just want to make those points that sometimes less is more.
If I could just add some color to that, I think Lorcan captured the field and the approach perfectly. One of the things with these patients, they're so difficult that it is often frustrating. Clinicians will get fixated on a diagnosis. And amongst cough docs, there is a small group of almost cultish GERD cough docs. And so there is a tendency to get fixated. It's GERD, it's got to be GERD. And just keep on taking the PPIs and it's GERD. And some of these patients will undergo surgeries, and on the other side of it, they're still coughing. So it is important. Lorcan captured it nicely there. I think there's value to telling a patient they have a disease of refractory chronic cough. There's great value in that, as opposed to telling them all the things that they don't have. And I think giving them something to walk away with. I have something. Whether or not that also includes an effective therapy is a different question. But knowing that it's recognized that it's real and there's an effort to treat it, I think is important, and not get fixated on a diagnosis that's just not supported by the physical exam.
Yeah, and that doesn't mean, of course, that there aren't patients out there that will respond to, good acid suppression. Of course there are. But it is this failure to accept that, we've gone down that route. We don't need to repeat it, but that we can make a diagnosis here. And then that leads in, because we do have interventions and some of them are not particularly ideal medicines.
Before we get to treatment, we're going to get there. We're going to get to mechanism treatment.
Yeah, I'm chomping at the bit,
No, you're great. You're great. I'm not going to call our patient fictitious. I'm going to call her an amalgamation. She's an amalgamation of many patients we've seen. Sandra, can you take us back to this patient and what kind of workup did this patient end up having for their cough?
Yeah, I can. And so just going back to the rest of the investigation. So the patient had a normal chest radiograph and spirometry. There was a negative metacholine challenge. Bloods were unremarkable. There was nothing atypic. No peripheral blood eosinophilia. FeNO levels were 31 parts per billion, which is in the intermediate range. And her provider had decided on an empiric course of treatments, and we did an additional medication trial as well. So the patient was given a course of oral steroids, 40 milligrams of prednisolone for 5 days. And this was followed by a trial of an ICS-LABA. And at review, the cost seemed to settle for a few days on oral steroids, but then returned pretty quickly while on ICS-LABA. And by the time review at 8 weeks, it was as bad as it ever had been, with the same severity score. So she was fully adherent with her ICS-LABA. The repeat FeNO was performed and it was 24 parts per billion, which was slightly down. So Dave, what would you do now? And how would these results how would you use these results to decide on your next step?
Yeah, this is great. And this is coming from me because I'm not, say, the cough expert that Lorcan or Brendan are, but I am a pulmonologist, so I'll see these patients in clinic. This is the time where I think taking in that philosophy of less is more that Lorcan was talking about becomes really important. It's like we have pretty good evidence at this point that this patient, without further investigation, we're probably not going to find a smoking gun that we're going to treat that's going to make their cough go down right away, right? Their FeNO is not that high. They've had steroids. They've had ICS. They haven't really responded to this. They had a negative methacholine challenge, right? So they're not having the hyperresponsiveness that we might expect in an asthmatic patient. And honestly, we say this all the time on the show, so maybe it sounds trite, but I think it's important, so we always repeat it, or cliche, is that you have to talk to your patient about this, right? And you have to see what type of patient they are and share what you honestly think is going to come from the diagnostic workup. I'll share an anecdote of one patient I had who actually came to me on the tail end, but she had had a provider before. She was very insistent. She wanted to know 100% what it was. And that had led to a CAT scan, which had some mild mediastinal lymphadenopathy. And then she had a mediastinoscopy. Then she had a complication of bleeding from that, and she was in the hospital. And honestly, she had no additional information from all of that testing that she ended up having. And so by the time that we sort of got there, I talked about, yeah, of course, there's always more tests. We could always repeat a bronchoscopy. We could think about CAT scan imaging. I will say I'm probably a little more flippant with the CAT scan imaging. If someone has never had cross-sectional imaging, I want to really, I'll do a physical exam and a chest x-ray, but I might say, look, a one-time high resolution CT scan, or even just a CT scan that's not low dose, is helpful for us to say that there's nothing really concerning there. But I will try to put off things like bronchoscopy where I don't think it's going to be adding too much for us. And then we already talked about this, but Lorcan and Brendan shared, then you start talking about what is this diagnosis, and you just try to tell the patient, this is what we think you have, chronic refractory cough or refractory chronic cough. We can treat it. We're not going to probably make it go away like this, but our goal is going to be reduce severity, reduce how much the symptoms interfere with your quality of life. And, if you have a patient who really wants diagnostic certainty, then you have to talk them through the risks and benefits of those further testing. So at this point, I probably might add a CAT scan to this patient. If they've never seen an ENT, I might think about an ENT, but otherwise I'm probably avoiding invasive procedures like bronchoscopy, trying to share with them what I think the diagnosis is, and then what our treatment goals are going forward, and then aligning my treatment approach with what they think is most appropriate for them. And curious what Lorcan and Brendan, as the experts in the field, think about that approach.
Yeah, I think it's about pretest probability and diagnostic yield, and our experience in adults. CT scanning is becoming largely ubiquitous. It's certainly cheaper. We can deliver it with a bit less radiation now. So I wouldn't disagree with you, Dave, about maybe getting a high-res CT chest in this case. What we are doing now in terms of the kind of global community of cough interested doctors is trying to get some consensus on, should CT scanning become a routine investigation in a patient presenting with chronic cough? I think at the moment, the evidence would point towards it not being routine. But the further a patient has gone down a journey, I guess the yield and the benefit of doing an investigation might increase to a degree. So you do have to weigh all those things up. But there is nothing wrong with getting a point in the sand. And this is where the doctor-patient relationship, I think, can be challenged, or indeed can actually flourish and can be helped by that kind of honesty, and say, look, we've gone down a route of investigation. We believe you've got a condition called either unexplained or refractory chronic cough. You have features of a very key element which we think drives the condition. You have features of cough hypersensitivity syndrome. And here's what we're going to do. And the options do involve, as we talked about, neuromodulatory therapy, speech and language therapy intervention. They do perhaps involve participation in clinical trials. And hopefully, it also will involve, in the not too distant future, a new treatment that we can actually give these patients.
And I should just add here, because again, this might be confusing for listeners. This is part of the reason I love this podcast, is that like I think the easy thing to do is get a CAT scan. It's probably what I do and lean towards. That's why I love talking to experts who say, you know what, how often is that positive? And the answer is usually not that much. And maybe the consensus is going towards not getting it. And maybe that'll change my practice, right? And that'll be better for maybe my patients and have less incidental findings. So we're all learning together. That's the whole point.
Yeah, an interesting thing there, and it's a good and the bad for the field. And going back to this, giving the patient a door prize, and that is a diagnosis. The white coat effect of the patient being reassured I have something, and now I have a physician that's listening to me and will fight to help get me better. And I think there's benefit for the patient mentally and probably presentation-wise as well. The bad of that is that, as Lorcan alluded to, we are now actively pursuing new therapies in cough, and these trials have been plagued by placebo effects because these are patients, they want to get better. And so they get on these trials, and it's an unfortunate reality of some of these trials is that they're really plagued by placebo effects. So that's the good and the bad of the door prize of giving a diagnosis.
I would jump in and just say, firstly, placebo, or what I would perhaps prefer to call a clinical trial effect, it's not just unique to the field of chronic cough. In fact, I've been recently particularly interested in a number of therapies that are being developed in another range of conditions that are probably associated with some form of sensory neuronal dysregulation. And again, I'm using that term in a very broad sense, and Brendan, I'm sure, could give a lot more precision to that. But things like chronic pain, things like chronic itch, and when you look at those clinical trials, it's actually remarkable the placebo responses that they see in clinical trials, and it seems to be particularly associated with conditions where there is a sensory perception. But actually, we know, and your listeners will know from the field of severe asthma and COPD and the biologic therapies, where that clinical trial effect of usual care in the setting of a clinical trial is quite a powerful influence on patients feeling better and so on. But working out what the real drivers of that phenomenon are, and how to at least modify and mitigate within a clinical trial, I think is a lot of what we've been talking about in this field. One point I wanted just to touch on, if you didn't mind, Dave and Christina, is one of the reasons why patients will do endless investigations, clinicians will order endless investigations, is this assumption that cough can only be a symptom, and it must be a symptom of some other condition. Now, don't get me wrong, I'm absolutely clear. Cough can be a symptom of asthma and ILD and COPD and lung cancer and bronchiectasis. Of course it can, and it should be, and will always be that. But we are now, as a community, starting to come to terms with this view that we need to recognize that cough can be a disease, a clinical entity in its own right, where there's a start, a middle, and an end, and we say, you've got this condition. But if you look at ICD classifications, at the moment, cough only exists as a symptom. In other words, it needs to be due to something else. Whereas I think the energy at the moment is to move towards this acknowledgement that in the right context, we consider chronic cough and conditions like refractory chronic cough as a distinct clinical entity, as a disease in its own right. And I think that's going to help the field.
Such an interesting conversation. And I'm thinking back to my earlier days in my fellowship where I would reassure patients that we will find a cause of this cough. So I think we have probably been part of the problem, that we're framing it that there is a cause and we will find the cause. And this new nomenclature and terminology will help to equip us to start thinking about cough differently. And as you said, Lorcan, to start thinking about cough as a disease rather than a symptom of a disease, which it can be too, but that it can be a distinct disease as well. So that was really informative. Thank you both. We want to start moving on to some treatment. So our patient is still symptomatic. Brendan, can you advise what we know mechanistically about cough that could maybe help our treatment choices in the patient?
Yeah. So again, thinking and recognizing a cough is a reflex. We have three areas in which we can intervene. One would be the trigger. So there's a trigger, a peripheral trigger, almost always in the airways, something that's activating those sensory nerves that will initiate that reflex. And so the classic example that many of you will have experienced will be a patient taking an ACE inhibitor. That small subset of patients that present with this dry cough when they're on an ACE inhibitor. And there the thinking is that this is due to an accumulation of bradykinin. And so the simple approach then is to obviously remove the ACE inhibitor and reduce the bradykinin and the driver. And so that's been a big focus therapeutically, is to try to identify triggers. Obviously, in a situation like refractory chronic cough and unexplained chronic cough, more than likely it's going to be difficult to identify triggers. We've actually been lucky in recent years. We found one trigger that we'll talk about, I think, later in the podcast, ATP, which may be a big driver. But for the most part, that's going to be difficult to identify triggers. The next place you can intervene is how that information is conveyed to the brain. And that is in the form of action potentials. And we heard about bronchoscopy earlier. Naturally, you're going to give some local anesthetics there to limit the activation. And so that's going to block the action potential. There's much more sophisticated ways of doing that these days. And that's an active area of research in the cough field to try to more selectively target those sensory nerves and their ability to produce action potentials. And then the last place we can intervene therapeutically is how those sensory nerves then talk to the brain. How do they communicate? And that, of course, is synaptic transmission. And there's a couple of ways we can do that. We can try to target the neurotransmitters that are released centrally. That's difficult because there's a lot of redundancy there in other systems, and a lot of those therapeutics are laden with side effects. But there are other approaches to try to amplify some of the inhibitory signals that we know regulate reflexes, things like opiates and GABA B agonists and the like. I think those are the approaches I think that best reflect our current thinking of how to approach this therapeutically.
Yeah, and we kind of unfortunately have a long list of failed drugs in this field, and it's not for want of trying, and the kind of the therapeutic targets are many, but as I say, the success has been limited. But at this point with this patient, you would be thinking certainly of as Brendan mentioned, perhaps using some kind of neuromodulatory approach. And definitely there are subgroups of patients who will respond to treatments like gabapentin and pregabalin. One of my favorite treatments, again, as a trial of therapy, and I emphasize this trial of therapy, would be amitriptyline. But again, side effects tend to be a problem, sedation, dry mouth, etc. And morphine, actually, the European respiratory guidelines do recognize that in some patients, a trial of low-dose morphine is all that we have for these patients. Because, as we've sort of highlighted with this sort of case, their lives are blighted. Their lives are really disrupted. And sometimes low-dose morphine in the background can be enough just to control the cough. I think it's important just to highlight that point. What we're trying to achieve is cough control. In fact, I ban the phrase cough suppression because that has very negative connotations, the idea that we're suppressing cough. Somehow the patient can't cough if they need to cough. What we want to be able to do is to really bring the patient's heightened, inappropriate coughing, often to relatively innocuous things, to a level where, and this would be this is the holy grail, is to identify a treatment that is going to bring the hypersensitive state down to a level that is more appropriate so that those patients can still cough when they need to cough. And indeed, I think that's what we have focused on.
Another element to that, Lorcan, is that, and we haven't been able to do this yet because we don't have great therapies yet, is that one of the ideas in the field is that there's a bit of a vicious cycle here. So cough's a pretty violent respiratory effort, and it will cause a lot of irritation. And I think we've all had that with an acute infection. When you cough a lot, you end up getting a laryngitis, of course, because of that really a massive amount of airflow. And so the hope is, we don't have evidence that it happens yet. The hope is that if you can quiet the cough for a time, that maybe that vicious cycle will quiet to try to reduce the inflammation in the airways. Because it is a real thing. I think we all recognize that with coughing, and some of these patients will be coughing 10, 20, 30, 40 times an hour during their waking hours.
Yeah, and it kind of brings just to mind, where we are. We really don't have very many options. And I think in the US, particularly, when there is the opioid crisis and the concern around drugs that have an opiate kind of basis, it is a shame that sometimes that's all we're left with. And indeed, one of the big over-the-counter sellers for cough and acute cough in particular is dextromethorphan. And I suppose this frustrates me a little bit, and I don't want to use your podcast to get on my soapbox and complain about the FDA, but I can say that, in the absence of really effective treatments, it was a shame that the position taken with drug, and Brendan mentioned how we've been recently looking at targeting particularly ATP signaling pathways, we think probably in the periphery. And by the way, these drugs do work, there's no doubt. It's just unfortunate that in the phase 3 clinical trial program, there was a larger than expected placebo response. And therefore, the difference between active drug and placebo was considered, at least by the FDA, not by the European Medicines Agency, interestingly, but by the FDA, not to be of sufficient size to justify approving it as a treatment. But the alternative we have for patients is either nothing or treatments that have side effects, neuromodulator agents, low-dose morphine, etc.
Wonderful. Thank you so much, Brendan and Lorcan. I would like to make sure that we get one more final question in. You've talked really nicely, talked about the mechanistic processes behind our current therapeutic options, but I'm wondering, are there any emerging treatments, new clinical trials? You both said this is a really active area of research still. Anything coming out on the horizon that you would want listeners to know about today?
I'll take a quick stab, Lorcan, and then you can jump in. So we talked about ATP, and of course we all know as ATP is the driver of energy in cells, but ATP, when it's in the extracellular space, has signaling mechanisms, and it acts through specific receptors. And really an extraordinary result and a bit of a surprise in a clinical study done about 12 years ago. A very small group of patients, the worst of the worst, on one of these P2X blocking drugs. Many of them experienced what would, for lack of a better word, look like a cure for them. So it's a subset of patients. And that has been consistently observed in these trials with these drugs. Clearly, there are a subset of patients that don't respond. But watch that space. I think there's going to be a subset of patients that are going to be really benefiting from blockade of P2X receptors. And there is, at least GSK is actively pursuing a P2X blocker. And keep your eye on China. China actually has a couple of drug companies that are very actively involved in launching their own drugs. So that's going to be an exciting space. And then we talked about opiates. They're more than the mu opiate receptors in the brain. And there are other ones that are less concerning in terms of addictive effects. And there is a novel opiate that's really has some striking results in IPF patients and in chronic cough. So watch that space as well. It's quite exciting.
Yeah, and I would just highlight that we know the gefapixant story. I've just highlighted a positive phase 3. It's now widely available throughout Europe and in Japan. And we've just recently seen published, and again, we'll provide the kind of links to this for your podcast listeners, but there's a real world study of Japan's experience with gefapixant. And about 2/3 of patients seem to gain benefit in terms of improved cough control. So I think the world of P2X3 modulation is still around. We've talked about some of these very interesting opiate-like receptors. There's one particular, nalbuphine, is currently in trial. Looks very promising actually in the IPF cough world. So again, not forgetting the fact that cough can be a symptom associated with other lung conditions like pulmonary fibrosis. But I want to give a shout out as well for, and particularly when Brendan was talking about action potentials and so on. One of the key elements that we need to drive an action potential is our sodium channels. And indeed, lignocaine or lidocaine is a classic pan sodium channel. But there are really clever ways now of targeting selectively some of the subtypes of the voltage-gated sodium channel family, particularly around about NAV 1.7, 1.8. And there are drugs that are being developed in the field now, which should, at least intuitively, reduce that activated, triggered action potential and coughing. And some of these drugs, as you may know, are being developed in the world of pain. Vertex, for example, is a company that are promoting their kind of NAV channel blockade. So look at the NAV channel blockade as being a potential new therapy. So I think there's a lot happening, Christina. I think the truth is we owe it to our patients to care, to listen, to take a good history, to organise investigations appropriately, to give trials of therapy, but at some point to be able to say, we've gone on a journey, we've investigated, you have a condition that is common, that is recognised, we acknowledge the burden. This condition is called refractory chronic cough, and you have features of cough hypersensitivity syndrome, and there are some things that we can do, and we hope that there will be new treatments for you in the very near future. I think, we're going to do our patients a real service if we can kind of communicate that message and also communicate to the young fellows that this is a field that is exciting. It has got a lot of scope, and it's a way in which you will still be connecting with your patients because it's a very patient-focused area of chest medicine.
Absolutely. Thank you both so much. This has been such a fantastic conversation that we've had, a little bit over an hour of talking about such an important topic. I think the first of many, hopefully, collaborations with Marissa and Sandra and the Irish Thoracic podcast. I think just quickly to summarize some key takeaways, I think it's just just listen. I'm going to keep listening to and come away with a different takeaway each time. What I learned from today, chronic cough is a disease. I think the framework that we talked about that Dave mentioned very early on, thinking about unexplained chronic cough, explained but refractory chronic cough, and unexplained refractory chronic cough is a good framework to have. We talked about how important it is to get a great foundational history and exam, using pretest probability when approaching our diagnostic evaluation. And I think for Dave and I and Sandra and Marissa, I think it's okay, if we don't always get the CT scan, but in the right patient, in the right context, we can. And then obviously ending with a personalized approach for both pharmacologic and non-pharmacologic cough control. But as we conclude today, Sandra and Marissa, I just want to hand it back over to you and to see if there's any final reflections or thoughts that you want to make sure that you can add today.
Thank you, Christina, and to Dave. It's been such an interesting episode, and we're really, really happy to have gotten this collaboration across the line. Thank you again as well to Lorcan and Brendan. On our Irish Thoracic Society podcast, we usually have an inspired piece which talks about the person's career. And I might just ask Lorcan and Brendan maybe to finish up with one piece for us. I suppose, in such an interesting career that you've had in chronic cough, is there one piece of advice that you'd like to give our listeners that you would have loved to have known starting out in your career?
Yeah, I'll start. And, I think don't take yourself too seriously and don't get too disappointed with rejection. Science, medicine is about good days and bad months. The good days are great. The bad months you just have to dig with them. And, I think, the first paper I got rejected, I was crushed. In reality, you got to take, the rough with the smooth. And I think, what I know now is that you can be successful, that every day isn't successful, and just accept criticism. Make your paper better, make your experiment better. That's what I would recommend.
And I'd add, obviously I come from a very different perspective, but I think it's an important one for all of us. And that is that finding that interface amongst scientists and clinicians is really key. And that's one thing that's really made this part of my career really exciting, is the ability to take ideas that are really kind of reduced and then apply them to patients. And then actually to see them tested experimentally in clinical trials has been extraordinarily rewarding. We failed a lot of times, and that's heartbreaking. But wow, it's exciting. It's fun to do, and always keep in mind that there is the potential that you could relieve some human suffering through these efforts, and I think that's really adds great value.
Thank you both for those lovely comments. I'm going down the kind of academic route in my career, but I'm still very early on. So it's very inspiring to know that there's lots of setbacks ahead, but that to keep persevering, and it's all worthwhile in the end. So thank you both very much.
Yeah, thanks everyone. Great advice. Don't get discouraged. If you have a chronic refractory cough, if you're treating chronic refractory cough, or if you're pursuing academic medicine, studying chronic refractory cough, there'll be good days ahead. This is a great episode. We really appreciate everyone tuning in to listening. Whatever feed you're listening on, you'll hear us come back together for some other episodes in the future. This episode was written and conceptualized by Sandra and Marissa. It was edited by myself and Christina, and great contributions from Brendan and Lorcan. We appreciate your expertise. And good luck out there. Thanks for tuning in.